The real reason that we're here is that U.S. surgeons now are going to be able to walk into the operating room and have all three, and soon all four of these discs available based on surgeon preference, vertebral body in-plate morphology, and the needs of the patient. And so you'll be able to walk in and you're going to have a whole armamentarium of different discs that you can place. So let's look at these discs here. The ProDisc, the heritage device, ProDisc-C is on the right-hand side. It has a flat end plate. It has keels that are 3.5 millimeters high. They're 2 millimeters along most of the length of them that flares to 3 anteriorly. The ProDisc Nova, which has a tri-keel, so you can see that would stack very nicely once we have the FDA approval for 2 levels in the United States. The keels are smaller. They are 0.95 millimeters, flaring to 2 millimeters in front, and they're only 2.5 millimeters high. The ProDisc Nova, or excuse me, the ProDisc-SK was then designed after those same parameters of 0.95, 2 millimeters, and 2.5 high. The ProDisc-Vivo on the left-hand side obviously does not have a keel. It has spikes that are fairly lateral. And so I should mention that if I could turn these discs en face to you, the 3 discs on the left all have a trapezoidal footprint. They're narrower at the back, and what that can lead to is less machining of the uncovertebral joints in back, trapezoidal, whereas the heritage device is more rectangular in shape. Briefly, I'll tell you that total knee arthroplasties go back to the 1860s, believe it or not. They gained steam in the 1950s and were popularized in the 1960s. Total hips popularized in the 1960s. My point in bringing that up is that we have over 60 years of information from orthopedics in how to solidly fix metal to bone. And fortunately that ProDisc has benefited from all of those advantages. All the materials and the biomechanics are the same across the entire family. Importantly, with this system, you will be able to walk into the operating room with just one tray. And that really helps with sterilization costs, which run over $70 per tray, and also breed familiarity not only for the surgeon but for the operating room staff. And so this match the disc system that gives you all this flexibility intraoperatively will come in just one tray. And so with that, I'm going to introduce or turn the floor over to Dr. Osama Ahmed, who's going to demonstrate the implantation techniques for the ProDisc-Vivo.
Thank you, Dr. Hall. So the cervical arthroplasty has become a huge part of my practice, and what I want to highlight today are some of the nuances between a fusion and an arthroplasty, and some of these nuances that I've picked up over the years that may not be discussed readily. So if we can focus in on the specimen, I want to describe a couple things here. So some dissection has already been performed in efforts for this discussion, but you can see that the disc is exposed, and we've done the muscle dissection off the spine, and we've gone quite lateral. And historically, when I trained and we were doing cervical fusion, I didn't necessarily go this lateral, but for the cervical arthroplasty, it's very important. So you can see here that the muscle has been dissected off the spine. I'm going to go ahead and put my distraction pins in. One nuance I want to share with you guys is that when you put the distraction pin in for a cervical arthroplasty, you have to have a little space or distance from the disc, okay? When I've done fusions before and the distraction pin is close to the disc, it doesn't really impede my ability to do it. So my goal for the distraction pins is that I want to span a majority of the vertebral body. I want to have distance from the disc, and I want my pins to be parallel, okay? Once we distract, I want to make sure that the distraction is not causing a kind of a wedge phenomenon. I want parallel distraction, okay? Nicole, come on in, let's get a shot, and let's make sure that the distraction pins are parallel. So where I've placed my pins are really at the 50% mark of the vertebral body. Okay, so looking at the x-ray, The distraction pins are relatively straight. They're right in the midpoint of the vertebral body, so I think that provides me enough space to proceed. Go ahead, go ahead, go. So now, if we zoom in, you can see that the discectomy has already been performed, and there are various ways to perform the discectomy. Some people use just curettes. Some people do use a drill. The important thing is not to violate the end plate. Okay, we want to maintain that end plate integrity. We want to go out lateral, frame in, take down that uncovertebral joint on both sides, and by doing that, that provides movement of the spine as needed for the insertion of the arthroplasty or the artificial disc. So if you look at the camera now, you look down the specimen, bilateral framenotomies have been performed. There's been a wide decompression. The cervical spine is loose. Let's get another lateral and let's see the difference in the distraction there just to show the mobility that we've created by doing the dissection. So you can see on the x-ray now that the space has widened. It's parallel distraction. It's not fish mouthing or wedging, okay? So if we can focus in on this device, so here's a trial, and you can see that there is a curve to the top of the implant here, and this is to mimic the end plate, the inferior end plate of C6, which is the level that I'm working on. We're working on 6-7. So this curve right here will mimic the inferior end plate of C6, and that's why in this particular specimen, we're going to go with the Vivo. So we're going to go ahead and put our trial in. The trials come in various sizes. Okay. Shot? Okay. So looking at the x-ray, you can see that my implant or my trial is not in all the way. You can see that the curve of the implant is going to take form with the inferior end plate of C6. I'm going to go ahead and advance my implant a little more. Shot. And that right there is probably a good size for the implant. It's covering what Dr. Hall was alluding to. You want a wide footprint. You want to cover the entire end plate surface area. So this is a 5mm height, and this is an extra large trial. So now that we've sized the 5mm extra large, we'll go ahead and take the artificial disc. Now on the artificial disc, want to make sure that the dome is upward or superior. That'll contact the inferior end plate of C6, okay? They have etched a mark right here, a line to indicate so. Shot. I know that I have a little more space to go, but I do shoot x-rays obviously to be safe and not to advance it further than it needs to go. I'm going to cover the entire end plate here. Shot. And you can see I can advance it just a little bit more, and that'll cover the entire space. Shot. Once the implant is in, go ahead and take this out. It comes off very easily. There's no displacement of the artificial disc replacement. And then just like any other cervical case, we can take down the distraction. The nice thing about this is that after the implant is in, there's no plate, no screws, no other tinkering. The implant is in, decompression's there, and you're done. Okay.
Beautiful. And there's ProDisc-Vivo. And again, that was selected at this level by Dr. Ahmed because of the morphology of the inferior end plate of this specimen. Now we'll have Dr. Ehsan Jazini show us the correct application of a ProDisc-SK in a patient that has a flatter inferior end plate.
Thank you. So when I first started practice, when I was thinking about disc replacement surgery, I was looking for that perfect patient, that 30-year-old with a soft disc herniation. And because in fellowship, we actually didn't do any disc replacement surgery. You can come down. So as I did more and more surgery, I realized very quickly, and I was fortunately in a practice that was big believers of motion preservation, at Virginia Spine Institute, that motion preservation is critical. And the more cases that I did, the more I realized that the boundaries that some of these studies that were done to approve these studies for FDA approval were not really true, and we can really push the limits. But the issue was that the different implants on the market have different morphologies. And so when ProDisc came out with these two different implants, it finally gave me, for a majority of patients, one tray where I can actually fit the disc to the patient at each individual level. We actually also did a study using AI and motion analysis looking at how there's hypermobility at the adjacent level when you have a fusion versus when you have disc replacement or hybrid surgery. And so that's where my adoption and how I went from doing about 5% disc replacement to almost 85% disc replacement with respect to cervical spine has happened. Now, the SK, which I'm going to show, is about probably 50% of the time I use that versus the Vivo, and it really depends on the level. Usually at the C6-7 level or the C7T1 level, where there's more flat end plates, or if the patient has a little bit of a coronal deformity or kyphotic deformity, it can be very helpful. So if you zoom in here on the actual implant, you can see that the actual shape of it is much more flat. It doesn't have that dome shaped, and it has a much smaller keel that goes into the bone. So we've already done the disc prep here. Can you please zoom in on the specimen? In terms of the initial nuances, and I'm going to point a few things out, is the exposure is the most important thing. You have to get the longest coli elevated off the bone. You have to get all the way out to the uncus. This is not, the surgery where you're doing a small cage in the middle with the fusion, like Dr. Hall mentioned. You have to have that full exposure. You do not want to take and remove these osteophytes, because that's a ground or bed for heterotopic bone formation. So really focus on your discectomy, and you can see that we've done a great job here by removing all the disc fragments, cleaning out the end plate, but without violating the end plate, and that we've gone all the way out to each edge of the uncus. You should be able to see the smiley face and be able to completely clean out that uncus. The goal here is to get the biggest footprint possible, and I would say 90% of the time I'm going with the biggest footprint. In fact, what really limits me with my sizing is how deep I can go without getting into the canal. So after you've opened up the disc space, and again, the most important thing here is you want to open up the disc space with either a spreader, with a blunt instrument. You do not want to use your distraction pins to do that, because you can definitely cause osteoporotic fracture or a failure of your pins in the actual bone. So once you have done that, please get an X-ray here. You can see we've placed very long pins. These are actually bicortical to prevent fish mouthing from happening. And you can see that this is opened up very, very adequately, probably even more than I would actually do. Then you place your trowel, and you remove your distraction. And I would say the majority of the time, when you pick a bigger trowel, when you get that big footprint, it actually auto-centers itself, whether you're using the Vivo or the SK. So we placed the trowel in. Please get an X-ray there. So you can see that we have about 99% coverage from front to back on this patient. Now there are nuances. In fact, when we were prepping this specimen for you guys to see, the implant was slightly to one side on the coronal picture. And what Dr. Bertagnoli mentioned is you have to go and clean out that edge of the uncus on the inframedial aspect to be able to get this centered. Now you have some situations where there may be a slight coronal deformity, and what's really nice about the SK technique is that you have this keel, the keel cutter. You can use your keel cutter to then make sure that you're centered. So basically you are placing your trial with the keel at the same time. So these are some nuances where you can really use the instrumentation and power it to get to what you want, which is really you want this implant to be perfectly centered. So we're not going to leave this room until we know this trial is perfectly centered before we do our keel cut. So you placed your trial in, and compared to some other companies out there where you have to put the trial in, then you have to take the trial out, and then you have to do a keel, the very nice thing about this, you placed your trial, you get your fluoro pictures to make sure that it's perfectly centered, and then you place your keel cutter over your trial. Please get a shot there. And you can see how we're driving the keel cutter over the trial. Now, what's really nice here is that there's this automatic stop, so you cannot drive the keel cut past where the trial is, which minimizes how many extras you have to get. So get a shot there, please. So now you can see that the keel cut has been performed, and we can backslap the keel cutter over the trial, and then we remove our trial. And so while I'm doing that, I'm obviously asking my rep to open the appropriate cage. I would say the vast majority of time, it's a 5, right? We do not want to overstuff the disc space. The most important thing, again, is to adequately open up and decompress the canal and the neuroforamens. Okay, so now we're placing our actual implant. With the keel cut, it's going to go where the keel is. Okay, shot there, please. And here, it's really important to take the distraction out. Shot there, please. Thank you. So now we're just going to remove the inserter, and then that's your final result.
Thank you, Dr. Jazini. Appreciate that. So a couple of things that I'll mention about the ProDisc cervical is that because of the keels, it is my favorite device for use in military aviation. I run a program for the U.S. Air Force. Even though I'm in a reserve component in the Air National Guard, I run a study group for the U.S. Air Force that I'm in charge for active duty Air Force Reserves and National Guard, whereby I have a study group of 10 pilots that have had herniated discs in their neck, gotten artificial disc replacements, and we've been able to get them back into tactical aviation. That's 9 Gs of force, and if you want to know what that feels like, you pick out a 160-pound person in this audience and you sit them on your head, and then you try and look around with 160 pounds sitting on your head. That's what 9 Gs feels like. I've got over 450 hours in fighters, and I can tell you it hurts. And so can these discs, as designed, stand up to those kind of forces? And so I started a fight with the U.S. Air Force about 6 years ago, and they allowed me to do this study group, and now we have 5 years of people flying F-22s, F-16s, and F-35s, and 1 F-15 pilot with great success. What we haven't proven yet on the military side is that these discs will withstand ejection forces, which is 12 to 15 Gs. It's a very short pulse, but we're in the process. We're about a third of the way through that study. So my point is that with the increased surface area of the keel, right? Because you've got your bony in-plate contact, and then you have your keel, which also increases your surface area. This is my go-to device for those type of applications, and it has been for our collision athletes, like our NHL players that have this device in them. And I know that you, and I think Tari as well, rugby players and other collision athletes. And so tremendous amount of stability with these devices, both with the robust primary fixation and the subsequent secondary fixation. And the semi-constrained design, where we have a fixed center of rotation, as Professor Bertagnoli mentioned, really leads us to have great stability to be able to restore people to their occupations for which they've trained after having cervical artificial discs.
Yeah, and in addition to what have been demonstrated before very well, thank you for the demonstration, is that arthroplasty is not only a motion preservation or replacement of the disc, it's also an indirect facet decompression procedure. So that means if patients do have neck pain and you do an anterior disc reconstruction, disc height reconstruction, you can offload the facets again. So it's not only a frontal part, it's also a back part. And some people that don't understand the principle well, they asking for a 3 millimeter prosthesis, a 4 millimeter prosthesis, but this is not right. You should do a better job by remobilizing the segments. So this is a surgical procedure and cannot be carried out by the disc. And if you think you downsize the prosthesis in height, you will generate no mobility. That's the problem. And we see this more and more surgeons asking for small height. But if you ask for that, it's better to do a fusion procedure and not a motion preservation, because motion preservation requires, especially if it's semi-constrained disc, we have an eccentric center of rotation, you need some height, not too much and not too little. So this is very important, and you have to place the center of rotation to the right spot. If you undersize the prosthesis, it's doing something else than if you oversize the prosthesis, if you move the center of rotation to the wrong spot. So this is very important, that it's also a facet decompression procedure and indirect. It's not only a disc replacement procedure.
Thank you, Professor Bertagnoli. I have a couple of closing comments. Real quickly, Dr. Jazini, Dr. Ahmed, any closing thoughts?
I think the big takeaway for me is that there's been a big paradigm shift for me in my practice. You really have to give me a reason for why someone needs to be fused. Versus before, it was like, you have to give me a reason why I can do a disc replacement. There's been a fundamental paradigm shift, at least in our practice, and the technology has been proven. It's been there for a long time, the actual core of the technology. Now we have just better end plates and better ways to place these implants in, and so I think widespread adoption is going to soon happen.
Thank you, Dr. G.
Yeah, and I think we touched on this briefly. I think if you practice in a competitive market, the consumers are driving this as well, right? Research, the information is available on the internet. They're coming in, they're seeking this out. So to have this as part of my practice and be well trained on placing these devices has really led to my practice becoming even busier in that sense. That's what the public and the community is wanting. A lot of people are well known, or they know enough about the adjacent segment disease and looking for alternatives.
Thank you. And to the giants of the field, here and here, and to Centinel Spine and their leadership for giving us this whole breadth of opportunity to treat patients based on their own anatomy and their own needs. So thank you, everyone. I appreciate it. Thank you for attending. I hope you have a good conference.